Welcome to AETCM, the Emergency Medicine channel. Today, in our series of videos, EM Rapid 2022, we'll be discussing about neonatal resuscitation. Most infants adapt well to the extrauterine life. Up to 85% breathe spontaneously without any intervention, and 10% will respond after drying, stimulation, and airway opening maneuvers. 5% will receive positive pressure ventilation. Intubation is required in 0.4 to 2%, and only fewer than 0.3% of infants receive chest compressions, and only 0.05% receive adrenaline. Although the number of infants or the neonates requiring resuscitative measures are very less, but we can't predict when and where we'll have to go for a neonatal resuscitation. A delivery in an emergency room is unpredictable. We can't say when and where we'll have to face such a situation. So, neonatal resuscitation is very important in all the emergency physician's life. Coming to the pathophysiology. The transition from the intrauterine to the extrauterine life is a high risk time. Even the normal laboring process places significant stress on the fetoplacental unit. Blood flow and hence the oxygen delivery are impaired during the time of the uterine contraction, and the compression of the umbilical cord, if it's all happening, also impair the circulatory flow and hence the oxygen delivery. Although the antenatal and the intrapartum ultrasound imaging and the fetal heart and tone monitoring have improved the surveillance of fetal well-being and helps in the prediction of fetal status at birth, is still inexact. The antepartum factors that pose a risk to the infants at the time of birth or like in the neonatal period are, there are like fetal factors as well as the maternal factors. So the fetal factors are intrauterine growth restriction, less than 37 weeks of gestation, multiple pregnancy, serious congenital abnormalities, oligo or polyhydramnios. Then the maternal factors are infection, gestational diabetes, pregnancy-induced hypertension, preeclampsia, high BMI, short stature, and preterm lack of antenatal steroids. The intrapartum factors that are posing a threat to the neonates are evidence of fetal compromise, that is any non-reassuring CTGs, meconium-stained amniotic fluid, delivering vaginally by breech, forceps or vacuum delivery, significant bleeding, cesarean section before 39 weeks, emergency cesarean section, and general anesthesia. Once delivery occurs, the newborn still faces a variety of risks at the transition to extrauterine life. These are the onset of respiration, the absorption of the lung fluid, the reduction of pulmonary vasculature resistance to allow flow to the pulmonary vascular circuit, and the closure of the ductus arteriosus and foramen ovale. Premature infants and infants who are small for gestational age are at risk because of the insufficient pulmonary surfactants, the fragile germinal matrices within the cerebral ventricles, and the thin skin that impairs thermoregulation. The transition from the sterile intrauterine environment to the extrauterine world places another burden to the newborn. Personal, competent and newborn life support should be available for every delivery, and if intervention is required, there should be like personnel available whose sole responsibility is the care of the infant. So the clinical features that we'll have to look for in neonatal resuscitation. Obtain a brief history from the mother, including the date of last menstrual period, the estimated age of gestation, number of fetuses, number of previous pregnancies, and number of living children, the history of diabetes, hypertension, or any other pregnancy-related problems. The prenatal care like blood grouping, the infectious serologies, genetic and ultrasound screening, and non-congenital anomalies should be asked for. We should ask for the history of any prolonged rupture of membrane, any history of fever, or meconium-stained amniotic fluid. Coming to physical examination. The need for resuscitation or routine newborn care is determined by the initial physical examination. For the term infant who is crying or breathing and who has good muscle tone at delivery, provide routine newborn care with the infant to mother skin to skin contact. A slightly more detailed examination using the Apgar scoring system has been used to assess the medical personnel in assessing the newborn for both for the need of resuscitation and also to check for the response to resuscitation. So the initial rapid assessment should occur ideally before the umbilical cord is clamped and cut, and we should observe for the tone and color, the adequacy of breathing, and we should count the heart rate. So coming to the Apgar score, basically we should evaluate the newborn at 1 minute and 5 minutes after delivery. So the Apgar score consists of 5 factors we have to check for. These are the heart rate. So if heart rate is absent, it is 0, less than 100 per minute is 1, more than 100 per minute is 2. Respiratory effort is absent is 0, weak 1, crying or normal is 2. Muscle tone, if it is limp, it is 0. Some flexion equal to 1. And active fully flexed is 2. Reflex irritability, there is no response, 0. Grimace, 1. Crying or active is 2. Color, if the baby is blue or pale, 0. Acrocyanosis, that is cyanosis at the extremities, give 1. And completely pink baby, give 2. If the 5-minute Apgar score is less than 7, continue the Apgar scoring at 5-minute interval until a score of 7 or more is needed. For infants requiring resuscitation, monitor the pulse oximetry with the probe placed on the newborn's right hand, that is to get the pre-ductal oxygen saturation of the. So coming to the setup, the equipment that we have to set up for a neonatal resuscitation. Ideally, the neonatal resuscitation equipment should be available. All these things should be available, and we have to keep a constant check. That is like a neonatal resuscitation may not be happening each and every day in an emergency room, but we have to keep a check. We have to keep a checklist and have to routinely check for these equipments are properly functioning and are available in our ED or in the neonatal resuscitation bay. So basically, the equipments required for neonatal resuscitation are a radiant warmer with a servo control temperature sensor, pre-warmed towels or receiving blankets. This is basically in setting of a labor room or immediately after delivery. That is while receiving a baby, while receiving a baby following delivery. So we should have pre-warmed towels or receiving blankets, then wall suction, suction catheters, bulb syringes, heated humidified oxygen source, compressed air source and oxygen blender, cardiorespiratory monitor, monitor leads, pulse oximeter, bag with TPs or flow inflating or self-inflating with manometer, mask of size 1, 2, 3 and 4, laryngoscope of 0 or 1 blade, endotracheal tubes 2.5, 3, 3.5 and 4 size, meconium aspirator, ETCO2 detector, then nasogastric tubes of 5 French and 8 French size, IV infusion equipments, IV fluids including 10% dextrose, normal saline, then umbilical catheter tray, curved hemostat, 2 iris curved forceps and not teeth forceps, then scalpel handle, blade, needle holder, scissors, syringes, gauze, then 3.5 French and 5 French umbilical catheters, then three-way stopcock, suture material, umbilical tape, povidone iodine solution, and polyethylene bags or plastic wrap. Basically, these include the warmer for to keep the baby. Basically to prevent hypothermia, we need a warmer with temperature sensor for the baby. We have to receive the baby in warm towels. Then we have to if at all required, we'll have to go for suction. For that, we'll require wall suction, suction catheters, bulb syringe, Oxygen delivery may be required. So for that, we have the oxygen source is required. Then, like for providing the oxygen, we may require a mask. Then bagging, like for providing a positive pressure ventilation, a bag mask will be required. So for that, bags should be there with that is self-inflating bags with manometer. Then, if at all required, we'll have to go for an intubation. For that, we'll require a laryngoscope, preferably like a zero or one size straight blade will be required. Then ET tubes will be required, and that is like of size 2.53, 3.5, or 4. Then meconium aspirator, ETCO2 detector. Then RT nasogastric tubes will be required. Then IV for securing IV access, we'll have to require the IV cannulas. Then IV fluids will be required. NS will be 0.9% normal saline, or if at all the baby is having a hypoglycemia, we'll have to correct that. 10% dextrose will be required. Then we may have to go for a umbilical vein cannulation. For that, we require umbilical catheters, three-way stopcock, suture material, umbilical tape, all these things will be required. Apart from that, other like emergency drugs like the adrenaline, all those things should be made available in the neonatal resuscitation area. So equipments are very important in a neonatal resuscitation because all these things should be available. All the equipments must be regularly checked and ready for use. Where possible, environment and equipment should be prepared in advance for the delivery of the infant, and checklists will help us in these tasks. Resuscitation should take place in a warm, well-illuminated, draught-free area with a flat resuscitation surface and a radiant heater if available. Basic idea is to prevent hypothermia. We should have a warm and well-illuminated area that should be like draught-free. Then equipment to monitor the condition of the infant and to support the ventilation should be immediately available, because it is not like a normal resuscitation. The neonatal resuscitation is following like a very rapid pathway. Like we have to do the immediate assessment in less than 30 seconds. Then we have to go for the basic manuals in less than 1 minute. If it's all not improving, we'll have to intervene in like not more than 1 minute time. So it is a rapid sequence of events are taking place, and the equipments for like monitoring and resuscitation should be easily available. Environment we have already discussed, like should be drought free. Then the warmth of the area should be like around 23 to 25 degrees Celsius, and for infants less than 28 weeks, the delivery room or the theater temperature should be like more than 25 degrees Celsius. Then temperature of the baby should be maintained between 36.5 to 37.5 degree Celsius, and hypothermia and hyperthermia both should be avoided. In appropriate circumstances, therapeutic hypothermia may be considered if at all that is happening after resuscitation. Then umbilical cord handling. Where immediate resuscitation or stabilization is not required, delay the clamping of the cord for at least 60 seconds. Clamping should ideally take place after the lungs are aerated. Where adequate thermal care and initial resuscitation interventions can be safely undertaken with the cord intact, it may be possible to delay the clamping while performing these interventions. Where delayed cord clamping is not possible, consider cord milking in infants more than 28 weeks gestation. Do not clamp the umbilical cord of newborn, term, or preterm who do not require positive pressure ventilation or immediate resuscitation for at least 1 to 3 minutes after birth. So delayed cord clamping reduces the need for blood transfusion, increase the neonatal iron store, decrease the risk of requiring treatment for hyperbilirubinemia, and for newborns requiring immediate intervention, the cord should be clamped and cut to allow for initiation of therapy. So, like delayed cord clamping should be done in all the babies except where an immediate resuscitation is warranted. Otherwise, we have to go for delayed cord clamping. Then initial handling is an like opportunity to stimulate the infant, and during the assessment, like we have to like take in the baby and dry the baby, so that will be giving a gentle stimulation to the baby and acting as a tactile stimulation. And we should not go for aggressive methods of stimulation. We have to dry the baby, rub the soles of the feet or the back and dry the baby, And by this time, the baby will be like, if active, the baby will be like responding. If not, we'll have to go for other resuscitative measures. So the tactile stimulation is initially like an opportunity to stimulate the baby, and it is basically like initial handling and drying will be acting as a tactile stimulation. Then checking for the tone and color. A very floppy infant is likely to need respiratory support, and color is like not a good means of judging oxygenation because diagnosis may be difficult to recognize, and pallor will be like in some cases baby will be pale and it will be indicating shock or sometimes hypovolemia due to any blood loss. So these color and tone should be assessed immediately. Then we'll have to check for the breathing of the baby. Is the infant breathing? If at all the baby is breathing, we'll have to go look for the rate, depth, and symmetry of the breathing effort. And we'll have to classify it as adequate, inadequate, or any abnormal breathing patterns like grunting or gasping. If at all the baby is not breathing, we'll have to term it as an absent breathing effort. Then we have to check for the heart rates. Determine the heart rates with a stethoscope and a saturation monitor. With a like we can connect the baby to a ECG monitoring also later for a continuous assessment. If the baby's heart rate is more than 100 per minute, then it is satisfactory. If it is 60 to 100, it is slow, and like we have to suspect possible hypoxia. And if the heart rate is less than 60, then it is like critical. We have to go for like all the resuscitative measures. So this is basically the neonatal resuscitation algorithm by the American Heart Association. So basically the neonatal resuscitation starts before the birth. The antenatal counseling and team briefing equipment check all happens before birth. So once a baby is born or the after birth, we have to basically ask for like three questions. That is it a term gestation? Is the baby having a good tone? Is the baby breathing or crying? If these three are fine, the baby can be stayed with the mother. We have to like dry the baby, make sure that the airway is clear, there are no secretions. If required, suctioning can be done, and then we can give the baby to the mother for the routine skin to skin contact. If at all anything is wrong with this, we have to again warm the baby, maintain normal temperature, position the airway, clear the airway secretions if needed, dry, and then stimulate the baby. If the baby is like after stimulation, if the baby is still gasping or apnea, or the heart rate is below 100 per minute, we have to go for positive pressure ventilation and connect to saturation monitor and ECG monitoring. But even after like stimulation, if the baby is like having a labored breathing or persistent cyanosis is there, we have to go for like clear the airway, maintain the airway, and supplemental oxygen if required, and consider CPAP. The initial like evaluation and the starting of positive pressure ventilation if required, like if the heart rate is less than 100 or if the baby is apneic or gasping. All these things should happen in less than 1 minute after birth. And after that, if the baby's heart rate is below 100 per minute, we have to check for any chest movements, and like ventilation corrective steps should be done, and we have to go for endotracheal intubation or laryngeal mask if required. And if after the ventilation corrective measures are done, even after that the heart rate is less than 60 per minute, then we have to go for definitive airway. We have to intubate the baby. We have to start on chest compressions. The chest compressions should be coordinated with the positive pressure ventilation. 100% the oxygen should be delivered. Baby should be connected to ECG monitoring, and if like venous like access is like not easily available, we have to consider emergency umbilical vein cannulation. And if the heart rate is still below 60 per minute after starting chest compression, intubation, 100% oxygen, all these things, even the heart rate is not, 60 less than 60 per minute, we have to go for IV epinephrine. And if the heart rate is even then persistently below 60 per minute, we have to consider hypovolemia, and we have to give the baby like fluid bolus, and we have to also rule out pneumothorax. And the oxygen supplementation for the babies, initially in the initial settings we have told, like if required oxygen supplementation should be given. So the target saturation is like not the routine saturation as in adults. So the target saturation varies with time. So the initial 1 minute, the target saturation is 60 to 65 percentage. At the end of 2 minutes, it is 65 to 70. 3 minutes 70 to 75, 4 minutes 75 to 80. At the end of 5 minutes, it is 80 to 85, and at the end of 10 minutes, it is 85 to 90. So this is the target preductal saturation that we should be aiming at. So this is a basic neonatal resuscitation algorithm. So once again, to sum up, after birth, we'll have to basically ask for 3 questions. Is it a term gestation? Is it like a baby having a good tone? Is the baby breathing or crying? After that, if all these things are fine, it will be going to a routine skin-to-skin contact with mother and the routine baby handling. If not, we have to go for the tactile stimulation, that is dry the baby, and even after drying, if the baby is apneic or gasping, and if the baby's heart rate is less than 100, we'll have to go for a positive pressure ventilation. We have to connect the baby to cardiac monitoring, saturation monitoring. After tactile stimulation, if the baby is breathing but baby is having labored breathing with cyanosis, we have to go for supplemental oxygen to reach the target preductal saturation, and we can consider CPAP also. And after if in the sick baby, like on positive pressure ventilation, even after starting positive pressure ventilation, if the baby's heart rate is less than 100, we can consider the corrective measures, chest movement should be checked, ventilation measures should be corrected, and we may have to go for an endotracheal tube or lateral mask airway. Even after correcting these things, the heart rate is still less than 60. We have to go for an intubation with endotracheal tube. Consider 100% oxygen. Then chest compression should be initiated, and the baby should be connected to ECG monitoring. And for a venous access, we can go for umbilical vein cannulation. And even after the chest compressions, 100% oxygen and endotracheal intubation, the baby's heart rate is still less than 60 per minute. We have to go for IV epinephrine. Then if hypovolemia is suspected, we have to give fluid boluses, and also we have to rule out pneumothorax. So this is again a tabular representation of the neonatal resuscitation. The things are similar. So here you can see that if the infant is breathing, crying, good tone, routine care. If the baby is having a poor tone or respiratory effort or respiratory distress, we have to warm the baby, open the airway, go for any suctioning, clearing the nose and mouth if required, and stimulate the baby. If the baby is non-vigorous, we can stimulate the baby after drying by rubbing the back, and vigorously we can rub the back several times. Next, if the baby is having labored breathing or persistent cyanosis with heart rate more than 100 beats per minute, clear the nose and mouth, monitor oxygen saturation, and provide supplemental oxygen to maintain the preductal saturation. That's the target preductal saturation, and we can consider CPAP. The other thing is, if the baby is apneic or gasping or heart rate less than 100, we can go for positive pressure ventilation and continue the positive pressure ventilation for 30 seconds, and consider any ventilation corrective measures if the heart rate is not improving. We have to give positive pressure ventilation with back mask ventilation at a rate of 40 to 60 breaths per minute using room air. And the pressure should be not more than 30 centimeter of water for term infants, and not more than 20 to 25 centimeter of water for preterm infants. That is basically to avoid the complication of pneumothorax. And if the baby's heart rate is less than 60 beats per minute, we have to go for chest compression. The CPR to ventilation ratio is 3:1. That is 3 compressions to 1 ventilation. That is 90 compressions and 30 ventilations in a minute. We can go for the CPR using 2 techniques are there. Basically the thumb encircling method and also the 2-finger method. The preferred one is the thumb encircling technique. By encircling the baby's lower end of the sternum and providing compression using the to thumb. Then we have to go for intubation prior to chest compression. Then even if the heart rate is less than 60 per minute, after compressions and ventilation, we have to go for epinephrine and like administer fluid if a hypovolemia is suspected. And we have to also rule out hypoglycemia and treat it if the baby is having hypoglycemia. So the drugs can be administered through IV access or like endotracheal through the ET tube. Umbilical vein cannula can be like inserted and can be used. If at all these are not like possible, we can go for IU access as well. So basically, the epinephrine dosage in units are 0.031 to 0.03 milligram per kilogram. That is like in 1 in 10,000 dilution adrenaline, we can give 0.1 to 0.3 ml per kg. So weight wise, it is 0.01 to 0.03 mg per kg of adrenaline. In intratracheal dosage is like a higher dosage. So that is 0.05 to 0.1 mg per kg. And like as a fluid, we can give normal saline 0.9 percentage, that is 10 to 20 ml per kg over 5 minutes can be given as a bolus. And if a blood loss is suspected, we can go for a O negative or a cross matched blood administration. If hypoglycemia is there, we have to correct it. And to correct the hypoglycemia, 5 ml per kg of 10% dextrose bolus is given in units, followed by 6 ml per kg of 10% dextrose as a maintenance dose. The important thing is that we should not give like solutions like a 25% dextrose or 50% dextrose in units to correct hypoglycemia. The fluid of choice in units for hypoglycemia correction is 10% dextrose. The dose is 5 ml per kg bolus, followed by a maintenance dose of 6 ml per kg. So this is basically a diagram representing the two techniques of providing compressions in units. The first one is the thumb encircling method. It is preferred over the second one, which is the two-finger method. So in thumb encircling method, you can see that basically all the remaining fingers are encircling the baby's chest, and the thumb should be pressing the lower one-third of the sternum, and we should be giving the compressions. In the second method, that is the two-finger method, basically the second and third fingers are used to give compressions to the lower one-third of the sternum. And this is a diagrammatic representation of the umbilical vein cannulation. So basically, umbilical vein cannulation, we have to cut the umbilical cord, that is like from around like 2 centimeter distance from the abdomen. We have to make a cut using a scalpel blade. And like the umbilical arteries and umbilical veins can be like visualized there. The umbilical vein will be a collapsed structure mostly at the 12 o'clock position. There will be 2 umbilical arteries at the 4 o'clock and 8 o'clock position. The umbilical vein may be having a clot or like thrombi will be there. We can remove it using a small forceps, and then we can insert the umbilical vein cannula. The umbilical vein cannula should be inserted, and like it should, in emergency, it should not be inserted more than 1 to 2 centimeter after getting the blood, the backflow. So once it is like we get the backflow, it should be connected to a 3-way stopcock, and we can suture it. The lower end can be like sutured and placed in position using the umbilical tape. So it is like in emergency, we can go for umbilical vein cannulation. Otherwise, we can go for like IO access. Otherwise, like in a resuscitation, we can give the drugs through endotracheal tubes. All the drugs like we are using in resuscitation can be given through the endotracheal tube. So this is basically regarding the neonatal resuscitation. So I hope like all of you have got an overview about the neonatal resuscitation, and all our like data is based on the AHA protocol, and also from the Centenari's textbook of emergency medicine. Thank you.